I see some French colleagues not sitting. So we'll start this third oral session. And I don't see Carla. Where is he? Okay. So we'll start with Carl Allen on HLH real life. Is it right? So we don't have music, no, just a speaker. So welcome.
Can you talk? Can you hear me? Is it okay?
I think so.
Yeah. Oh, we're not doing this one, right? Is this the real HLH presentation?
Who starts the?
Okay. So while he's getting that teed up, I can just say again, sorry, I was so engaged in conversation stimulated by the meeting that I lost track of where I was. But this, I think, the talk I'm about to give is a real-world experience of the use of emapalumab in the U.S. There have been about 170 patients treated during the 3-year time period that this represents. And we have, I think, about 105 of those patients represented. And I'll say, like, Ashish had his brilliant entrance. Jean, I think, characterized sort of episode 1, episode 2. This is going to be the highlights of the movie trailer to get you super excited about the data that's going to come once it gets analyzed. So what this is going to represent is really characterizing the patients who have been prescribed emapalumab in the U.S. during the first 3 years that the FDA approval was in effect. And so as far as the outcome data, that's sort of in process, and so stay tuned. That'll be the first episode.
Can we have Carl Allen's slide, please?
So
it appears here, but not here.
So we need the real HLH slide. It should be.
I see some slides here.
Should we go to the next speaker and then?
The slide is only here, but it's not in front. So there is probably something.
Yeah. Well, so this is the wrong slide deck. So if it may be most efficient just to go to the next speaker, and then we'll fix this in the back if we can't find it. So it should say something like real HLH or.
It's not on. Hey, Carl, I think we'll just swap order. How about
Okay,
that?
Yep, no problem.
Yeah.
Thanks.
Yeah, that's correct, yeah. So I'll talk and then we'll sort out your slides.
So we start with Michael?
Do you want some help? Yeah. Okay.
So we'll just swap
Okay.
order.
So Michael, we'll start. I hope. Okay, it's okay.
Okay.
So please.
Hi. All right. So I'm Mike Jordan, as you probably know. And I'll be discussing our abstract, deep proteomic analysis of FHL patients. Oh, great. Thank you. So, characterizing the nature of the hyperinflammation that we see in HLH has really been important for our field. I think it's been productive for defining new therapeutic targets. And prior efforts have relied on, a combination of either educated guesses or limited lists of analytes, things that we know how to measure, basically, right? So it's not based on necessarily the biology, it's more the technology, right? And so the broadest effort to date was an effort that Carl Allen and I worked on in 2021, published, comparing a very broad panel of protein analytes measured by Luminex, so 135 proteins. And we compared patients with sepsis and those with HLH, and we saw, not surprisingly, a strong interferon signature in the HLH patients. But I guess there's never enough, right? So that's still limited technologically by what is just on the on the list, right? So we wanted to characterize inflammation in HLH more broadly to really more deeply understand what's going on and try to minimize this potential for bias. So we've moved on to another platform that's called SomaLogic, and so this is a proteomic platform. It's based on basically aptamers. So this company, it's a company that creates millions of different aptamers that uniquely bind proteins. So they can quantitate and identify a lot of different proteins based on their binding with a very small sample. And so the latest generation platform is called the 7K platform. It quantitates almost 7,000 proteins that can be measured from whatever body fluid you want. And some of these analytes, of course, it may be more than one analyte for a single protein, or for a single gene, I should say, excuse me, if you have different isoforms. But it's about 6,500 unique genes that you can assay the products of. And so this is about a third, or not quite, but about 30% of the genome. So while it's not everything, I think we're getting very close to being truly unbiased in terms of what we can actually measure in the proteome. And so there's a lot of data published with a somewhat older platform that's 1.4K. So as you might imagine, it's a lot smaller. So what did we do? So we took a small number of patients, samples from patients with either FHL or pediatric controls. And so there's 6 patients with familial HLH and 6 controls. And there's the median age was, as expected, under a year. This was around the time of diagnosis, before therapy. And most of these patients, I think, except for one, had a clear genetic etiology. And I should point out that these samples actually were from our wonderful collaborator, Joanne Jakubowicz in Tel Aviv, who's actually for years has done some amazing useful banking. And so I think we're beginning to see the fruits of those efforts with studies like this. So what did we find? If the slide will advance, maybe. Here we go. Yeah. So when we look broadly across these samples, what we see is it's very clear how to distinguish patients with FHL from these sort of age-matched pediatric controls. And you can see on the PCA analysis that that these really separate out nicely. You can see it on the heat map as well across many analytes. And if you look at this as a volcano plot of specific genes, again, you can see there's a really nice distribution, or separation, I should say, between these groups, and is evidenced by the fact that there are many really highly differential proteins. And so it's a little hard to read, but so if you look at some of the sort of key findings, so some of these things are exactly what we expect, right? They're disease-related, maybe even disease-defining. Things like ferritin, so those 2 dots, all the way to the far right are basically ferritin light chain and ferritin complex of both heavy and light chain. But also we see CD25, we see LDH, we see CRP, these things that are well expected and known clinically. Also, not surprisingly, we see strong evidence of interferon gamma response, things like CXCL9, CXCL10, IL-18 binding protein, right, which of course is one of the most interferon upregulated genes out there. Also small GTPases like GBP2 are well known as interferon response genes. Also we see other genes sort of in this interferon or related pathway, so IL-18, which is well described, of course, as a interferon gamma inducing factor, or for that matter, would simply be expected to accumulate when you produce more IL-18 binding protein. We also see IL-1 RL1, which is also known as IL-33 receptor, or ST2, which is important for promoting interferon gamma response in viral infection. We also see a lot of macrophage-derived analytes, a lot of scavenger receptors like MARCO and MRC and MSR. These are, well-described macrophage scavenger receptors. Also MFGE8, which is an apoptotic cell receptor. We also find increases in HMOX1, or heme oxygenase. So some of you may be familiar with heme oxygenase because humans that are deficient in heme oxygenase have sort of a chronic MAS HLH phenotype. And it's thought to be anti-inflammatory. So this really confirms this sort of impression that we're already aware of. And then there are a variety of genes that were downregulated, which, as far as at first glance, made no real pattern, almost no sense at all, until we started realizing that these genes that are downregulated are associated with things such as pre-B cells, right, in developing in the bone marrow, or directly with platelets, right, or neutrophils. So things that, in fact, if a patient is thrombocytopenic, you would expect to see less of these proteins shed into the serum. We also saw decreases in creatinine kinase, so the muscle isoform, the brain and the muscle isoform. So kind of strange, but if somebody's on steroids and they're sick, then while these are early and these are before a substantial therapy, maybe their illness has led to decreases there. So we think that these sort of down-regulated proteins are maybe more reflective of the overall context or secondary things such as cytopenias. So if we characterize these gene changes between the FHL and the healthy controls systematically, a good way to do that is using GSEA. So you may be familiar with GSEA, but basically you take your gene set of interest and you compare it to many hundreds or thousands, I think, even of other prior gene sets that have been thoroughly annotated. And within the big GSEA universe, there are a number of them, about 50, that are called hallmarks that have been validated across literally hundreds of gene sets. And so when we look at the GSEA hallmark sort of characterization of these changes, this is what we see. So, and of course, in this case, what we're actually measuring are proteins. So we're essentially translating the protein back to the gene and then running that through GSEA. And so what we see is, again, not surprising, the top of the list, we see things like IL-6, JAK-STAT signaling, interferon gamma, IL-2 signaling, and so I have things highlighted here that are indicative of inflammation or inflammatory cytokines. We see evidence of metabolic activation, whether it be through OXPHOS or glycolysis. Again, also very indicative of activated immune cells. We'd expect that. And then finally, that we see evidence of transcriptional activation, mitosis, also very much consistent with an activated T cell response. So, you could say that's kind of a slam dunk, right? It's pretty easy right here to distinguish healthy controls from FHL patients. So, maybe it's too easy, right? So, HLH is so different from healthy controls. You could see depending on your stringency, it seemed like most analytes could actually be somewhat different between the two different groups. But there are a variety of different, controls that I think are potentially relevant when you're thinking about how do we sort of define or deeply understand HLH. So a number of which have been published already, and they're using this somewhat older, smaller platform, and these data are publicly available. So we wanted to compare our results to some of these prior studies in specific patient populations. And so to do that, we would normalize our data against our controls, normalize their data against their controls, and then compare these normalized data with each other. But also we had to cut down our analytes down to the smaller list. list. And when we cut our list down to about 1,300 analytes to be consistent with comparing across platforms, we still see, again, a very strong signal for the FHL patients, very easily distinguishing them. And in this case, we're actually comparing them to our controls, but also controls from 2 other completely unrelated experiments in children, or data sets, I should say, in children that are done by, again, different platform, different groups, different reasons. And we still see that there's a very strong signature of FHL compared to the healthy controls. But if we say, just the analytes that are, with some stringency have changed by at least 1.5-fold with a p between the groups of less than 0.05, we end up with about 500. We still end up with about 543 analytes. And so one data set that's out there is from Scott Kana, and so they published this relatively recently. They looked at patients with MAS, and they were among other patient sets. And as you can see, in terms of the PCA analysis, the FHL patients separate out somewhat from these MAS patients, but in a way, the MAS from their data set almost separates better from our controls and our FHL patients. But there's still a significant sort of overlap of genes that are, so this is differentially expressed genes. So in other words, in the MS patients, how are they different from their controls? Or in this case, in our FHL patients, how are our patients different from our controls? And these 2 sets, how much do they then overlap with each other? And we can still see quite substantial overlap. And if we do sort of a systematic characterization by GSEA of the genes, either that are not sort of in common, either MAS or FHL related, or that are in common in this overlap, so we see this list right here, and it's actually a fair bit shorter, and part of the problem is we're losing some power when we do this normalization, obviously decrease the gene list, and so I have a hard time quite saying much about this, but what we do see in common is an intersection is a complement signal, this allograft rejection, which is evidence of a strong cellular immune response, and the things that actually come up as sort of differential for FHL are, again, additional inflammatory markers, some JAK-STAT signaling, suggesting that it's perhaps stronger in the FHL patients, or it's more prominent than in the MAS patients. So, well, how about going a different direction? So we can compare FHL with sepsis. Again, same principle here. Also, again, the sepsis patients do seem to be somewhat different from both our FHL and our control patients here. How much this reflects the specifics of the experiments of their data set, it's hard to say for sure, but again, you can see there's a really obvious FHL signature. It's not quite as clean with all these sepsis patients. There are, in fact, a few controls when you have this larger clustering that appear to be kind of a bit closer to our FHL patients. Again, if you do the same sort of thing, looking at the genes, the things that they have in common and the things that they don't have so much in common, not surprisingly, in sepsis, there's this obviously this TNF signal that's much more prominent than in the HLH patients. In the intersection, though, curiously, there's STAT5 signaling. But again, for the FHL patients, there's this strong interferon response that we, as I mentioned previously, we published is really quite distinctive from sepsis patients, along with additional sort of inflammatory signaling. But what about everybody's sort of favorite thing du jour, severe COVID or MIS-C? So a similar analysis comparing to either sort of MIS-C patients, right, or to severe COVID. Again, in all these cases, these are inflammatory processes, whether you're talking about sepsis, MAS, or COVID, so there is some overlap. There is, I would say, more non-overlapping genes, I think, somewhat obvious here, right? But again, just looking at the heat map, even if you're nearsighted and your glasses are on the table, right, you can still tell that there's this really strong sort of signature here that is FHL. And if you look at, in this case, compared against severe COVID, what they have in common, they're both inflammatory, right? So maybe that's a fancy way of finding out something simple. But also, again, FHL still shows a much more prominent interferon gamma and other cytokine signaling sort of phenotype compared to COVID. And then likewise with MIS-C, again, there's this common there, of course, inflammatory processes, but FHL has a much more prominent, sort of cytokine-driven sort of phenotype. So in conclusion, I think it's obviously, I think, pretty clear to say that FHL is a hyperinflammatory state which is very broadly distinguishable from healthy controls. It's driven mostly by interferon and JAK-STAT signaling, and it's distinct from these other hyperferritinemic syndromes, at least in these sort of, I would say, relatively limited, size data sets. But there's substantial overlap, and I think we're still, working to try to really understand this more deeply, beyond this initial analysis. And so, just wanted to thank, in particular, Adi Lorenz, who's really been a driving force in terms of this analysis, and also, in particular, Joanne Jakubowicz, who's really been the critical partner here, who's been banking these precious samples. So, thank you, and I'm happy to take any questions.
Thank you. We are already a little bit late, so maybe only one question while the next speaker is preparing. Is it Carl for the next speaker? Is it okay for the slides or no? Please.
So, Mike, just a methodological question. I assume that among your familiar HLH patients, there were some patients with perforin deficiencies, and if so, did you find that back in your signature, in your protein signature? Was perforin one of the proteins that was preferentially decreased in this particular group?
Interesting question. So as a group, no, but that's of course because not all, right? It would have been quite disparate within the group, depending on the genotype, but we didn't actually look at that on an individual basis. So I can't answer that directly, but I'll go take a look. Yeah. Yeah. All right. Okay.
Thank you. Thank you. So I hope the slides will work this time.
Thank you.
Okay.
On here. Okay. So I already gave you the intro to the intro. So I just wanted to again, thank you for your patience. Sorry for the mix-up. So here we're going to present the real-world experience with basically what this study is answering is who's using emapalumab, where, and how. And again, the outcome data will be soon to follow. So for disclosures, the study is a collaboration with SOBI. Several of us are on advisory boards with SOBI and other organizations. If I can read this. So just a little background. I think everyone here understands what hemophagocytosis is, sort of a syndrome of pathologic inflammation that's been discussed a lot at this meeting. What exactly is HLH versus other conditions, I think will be maybe something to discuss at future events. I think we all know that this is a super challenging syndrome with 30% of the patients having an inadequate response to conventional therapy. Then emapalumab's a drug that blocks interferon gamma signaling that we've talked a lot about over the last several years. There were several clinical trials that Michael Jordan and Franco Locatelli have led that have been discussed at past meetings. It's now FDA approved in the United States. And so, again, this study is going to outline just how is this drug being used now that it's been approved. So this was a retrospective chart review of patients who got at least one dose of emapalumab between November 20th, 2018 and October 2021, so about a 3-year period. And patient data were evaluated from the time of emapalumab initiation until there was no further data available, or until the end of the study period, or if the patient passed away. And I think this shows you that, we had a pretty good distribution. So this really is sort of, I think, a pretty reasonable representation of sites around the U.S. So we had 105 patients across 33 treatment centers. So again, I think if most centers treated only one or two patients. And this shows you the type of patients that were treated. And you can see here, this is a pretty representative of United States sort of heterogeneous population. And interestingly, it was a pretty even mix between primary HLH and secondary HLH. And there were a handful of cases I'll discuss that didn't have HLH, but people were able to use the drug. And you can see that this sort of breaks down as what you'd expect. The primary HLH patients were much younger, so a median of 1, average of 4.7 years. And of course, they tended to meet HLH criteria, although sometimes we can't tell the difference at this point whether they were diagnosed with a gene and how symptomatic they were at the time that they were treated in this first pass, but we'll get that information later. And so the patients who had secondary HLH were actually quite a bit sicker than the primary HLH patients, probably, because Dr. Carcilla doesn't call hematology oncology, at least tried a few other things. But you can see a lot of these patients were in fact quite sick in the ICU. A good percentage, 22% of the patients primary were on the vent, and 50% of the patients who had secondary HLH. Okay, so for the patients with primary HLH, the clinical characteristics, so this is pretty typical distribution of genes that you'd expect, at least in the United States. So the genetic mutation was known in 35 out of 38 of the patients reported to have primary HLH. And then, again, about half the patients were reported to have infections. So I think you could probably presume that about half the patients were probably presenting with pretty significant flares associated with those infections. Secondary HLH, I think the triggers were probably more multifactorial. To be defined as secondary HLH, one had to have malignancy or rheumatologic disease. This is the FDA label definition of secondary HLH. But the majority of those patients also had infections. Okay, so reasons for initiating. So refractory disease was more common in secondary than primary. Recurrent disease more common in primary than secondary. And progressive disease, again, I think is distributed as shown here. Okay, so again, the FDA label is for second line therapy, and so I think as what would be expected, most of these patients had received some kind of therapy, and it doesn't designate what kind of therapy you need to receive. You don't need to get a topicide for most insurance companies to approve emapalumab, but at least to have received some kind of therapy, and then, but still over half the patients received chemotherapy drugs before they started emapalumab. Okay, the dosing is kind of interesting because, again, the label suggests that you can receive between 1 and 10 milligrams per kilogram, but recommend a starting dose of 1. But it looks like most people don't follow the rules. There's sort of a median of 1.4 milligrams per kilogram in primary, and actually sticking a little bit more to the label at 1.1 in secondary, but the range goes basically from 1 to 10 and then 1 to 5 in the starting dose. And some of these patients were on therapy for quite a long time. As you can see here, as you'd imagine, some of these patients who either aren't eligible for transplant, who remain on chronic emapalumab, or it just takes a while to get a transplant. And it seems like the secondary HLH patients resolve their problem one way or another a little bit more quickly. But it does show that the drug's sort of tolerated for quite a long time in some cases. Okay, so some patients were able to receive emapalumab who didn't have HLH, and the reasons cited for this we can get into, I think, in a subsequent talk, but I think that there is some consideration to give it as part of conditioning therapy for transplant in patients who perhaps would have a challenging graft, or after transplant for patients who were perhaps at risk of losing their graft. Okay, so study limitations, of course, this is a retrospective chart review. This is what really happens in the real world. The data are reviewed pretty rigorously, so the quality of the data should be reliable, but there are certainly some missing or incomplete information, as we're recording what happened in real life, and this isn't a prospective trial. And of course, since emapalumab is a second-line treatment, there's sort of a risk of bias towards patients with poor prognosis. So I want to extrapolate this to represent a general HLH population. Okay, so this is the first step in trying to really understand how useful is this drug, how are people using it, are there any sort of signals that can add or enrich our data as we start to figure out how to use this drug in patients for whom it's indicated. So future outcomes, we'll have the treatment responses to emapalumab, a specific bone marrow transplant outcome study, as well as survival-related outcomes coming over the next 6 months. And again, just put another plug for the Into HLH registry and I think it demonstrates the power of trying to understand what kind of practice people are doing. If we can as many patients as possible in this registry and Histiocyte Society registry, I think we can learn a lot more together. And you can see there's a huge list of collaborators. Many of you are in the room, so thank you very much. And on behalf of the study team, thank you for your attention. Happy to take questions.
Any question in the floor? I look for the internet question.
If no one has a question, I can pick up Mike. Is there anything else you'd like to add on this experience? Or any of the other collaborating investigators? If not, oh, yes, we have a question here.
Do you know if there's been any discussion because of the cost and just issue drug wastage, of having different vial sizes rather than standard? I just looked up, they're 10 and 50, because it's an issue with so many of our drugs, and that can drive what we decide not to waste a vial. So we'll either round up or round down, with that. I mean, this, to the environment, this drug probably isn't toxic. I mean, it's more of an issue with cytotoxics, but that and I realize from a manufacturing standpoint it's an issue, but has there been any discussion of, especially if it's going to be used in adults, let's say having a 70, milligram vial, or different vial sizes?
Yeah, I think it's a really important question, and I think we can, this study will capture why patients use the drug, but it's maybe not going to necessarily capture why people unable to use the drug. So I think that certainly the cost issue is something that can be brought up with SOBI and sort of discussing the rationale. And I think that what it does though is compared to other drugs, I think we in the U.S. once the drug is FDA approved, you can kind of use it for whatever you want, sort of for the art of medicine. But when there's a really high cost associated with it, you really require much more levels of approval, especially through insurance, hospitals, et cetera. So I think there's sort of much less pulling off the shelf and just trying it for things beyond the indication. And I think that's kind of reflected here, that most of what you see is sort of reflecting truly kind of label appropriate use of the drug. But yeah, I think that's an important question that we should talk about. Pharmacoeconomics is another good discussion point for a future symposium. Okay, thank you so much.
Thank you. I think it's Anita Chaudhary, but I see Eli, so I don't know. Anita Chaudhary, wait. Are you here? I think your slides are up to. You have the microphone? Or? Does the microphone work?
No,
Yes, it's
okay. Hi, everyone. First of all, thank you very much for inviting me to present our work here and on distinguishing sepsis from sepsis HLH. At the end of the talk, I would also like to receive suggestions along with questions if you have any. Yeah, so in countries like India and other developing countries, this is an important issue because we have a high infection burden, and most of the deaths in children happen due to infection and sepsis-associated deaths. Yeah, and although I'm not a clinician, but my clinician friends also often say that they do see HLH-like features in their sepsis children, and they often find it difficult to decide upon the treatment, as HLH requires an immunosuppressive therapy, whereas it might be detrimental for sepsis. So they wanted to have a clear markers to diagnose early sepsis from sepsis HLH. Yet based on the clinical features, it's difficult because many of the clinical features between the two conditions overlap. So HLH is, as you all know, these are the clinical parameters. If any child is sick and satisfy 5 of these 8 of the criteria, we identify that as an HLH and treat accordingly. whereas this has certain limitations that it is primarily developed for primary HLH, and not all of the 5 criteria may be present early during the disease, and some of the tests are not available at all the clinical settings. So there are some other methods to diagnose or distinguish between the 2 groups have been suggested, such as based on H score, which is used mainly to identify adult HLH patients. And a few studies have also suggested the utility of using 4 out of 8 HLH criteria to diagnose HLH. So since the clinical features overlap and it's difficult, it's challenging to diagnose solely based on the clinical features, immune signatures might be helpful in distinguishing the 2 conditions. Even though both HLH as well as sepsis patients do present cytokine storm, yet in sepsis, they also present, we also see a co-occurrence of immune suppressive states, whereas HLH is solely hyper activation of immune cells as well as hyperinflammatory state. Yet the studies comparing the 2 conditions, sepsis from sepsis HLH, are very few. And maybe I think there are a couple of studies which have parallelly looked at the 2 conditions, immune signatures in the 2 cohorts. So one of the study is it's a recent study by Chaturvedi et al. Group, and they have shown that that activated CD8 T cells above a certain cutoff of 7% may be a useful marker for the diagnosis of sepsis from sepsis from HLH. And other study has also, one more study has also suggested the role of cytokines, mainly interferon gamma and IL-10, in distinguishing the 2 syndromes. So from India, most of the literature is limited to the case reports. So we really have a lack of studies actually exploring the immune signatures between the 2 groups to aid in diagnosis. So our study objectives were to explore T-cell phenotyping as well as cytokine profile between the 2 groups, sepsis and sepsis HLH. So ours is a cross-sectional observational study. So we enrolled around 68 children children with sepsis between the age 1 to 16 years. And some of the children, since the samples were collected around the COVID time, some of the children also diagnosed with MESI. We excluded them from the current analysis. They were analyzed separately. So from these, we collected the data or analyzed only children for which we have at least 5 of the HLH 2004 criteria, clinical data available for at least 5 of the HLH 2004 criteria. Of these children, we set a criteria of 4 instead of 5. So those who satisfy 4 out of 6 or 7 measured HLH 2004 criteria, we considered them as HLH. And those who had less than 4 criteria satisfied were considered as sepsis. Within the HLH group, we had certain some children with underlying malignancy and other autoimmune conditions. We identified them as other HLH, other secondary HLH, and remaining were considered as sepsis HLH. We also enrolled certain primary HLH and some primary HLH patients, as well as healthy control children. So this is our demographic and clinical features across the groups in our study cohort. So as you can see, in sepsis, the clinical features for which are commonly present in HLH are not seen in sepsis, except for ferritin, where almost half of the sepsis children with sepsis having a ferritin level greater than 500 nanogram per ml. In our sepsis cohort, the sepsis HLH cohort, 3/4 of them are male, and most of them are having bacterial infection. So next we looked at the clinical feature median values for all the clinical parameters from the HLH 2004 cohort, 4 criteria across all the groups. So as you can see, the sepsis HLH has reduced cell numbers for across all lineages when compared to the sepsis. Though if you can see, the neutrophil counts are reduced in sepsis HLH, the degree of reduction is not as severe in primary HLH, so they may not be neutropenic, but yet there is a reduction in the cell numbers as compared to sepsis. So the overall reduced cell numbers across all lineages might indicate a suppressed marrow suppression or reduced marrow activity in sepsis HLH as compared to sepsis. We next compared the H-score, which is usually used for diagnosis of secondary HLH in adults. So in adults, the cutoff is 169. So those who have a cutoff above 169 are considered are identified as HLH. In our cohort, most of the sepsis are below that cutoff, and most of the HLH are above that cutoff, and the H-score is significantly different between all the HLH and the sepsis. Other markers of soluble markers of immune activation were elevated. So soluble CD25 is elevated as compared to sepsis in all the HLH groups, as well, including sepsis HLH. Soluble CD163 is also elevated in all the HLH groups, whereas in ferritin, we do not see a significant increase in as compared to the sepsis in the HLH group. Next, we try to see if these clinical parameters combined together, whether they can separate out the two groups, sepsis from the HLH. So as you can see in A, the PC analysis shows that there is some separation between the two groups based on the clinical parameters, yet there is a significant overlap. So the blue one is the HLH and the red one is sepsis. So when we subcategorize the HLH, further categorize the HLH, we found that the primary HLH separates out clearly from the sepsis. The purple one is the primary, whereas, the purple one is primary, whereas the green one, which is sepsis HLH, shows considerable overlap with the sepsis cohort. So since we see the clinical features, though they are able to separate out other HLH clearly from the sepsis HLH is still showing considerable overlap based on the clinical features. So next we explored the immune signatures. So to see if they differ based on their immune profile, we looked at the T cell proportions and its subsets. So T cell, in first graph, since we have very small numbers in sepsis HLH group on which phenotyping was done, we also analyzed sepsis with all HLH pooled together. So in first, as you can see, T cell proportions are not significantly different between sepsis and sepsis HLH as well as the other HLH groups. The subsets, however, are significantly different between the two groups, sepsis and sepsis HLH, with reduction in CD4 T cells and increase in CD8 T cell subsets. And that is also reflected in our CD4, CD8 ratios. Next, we looked at the activation markers on the total T cell activation as well as exhaustion markers. Activated T cells were identified as HLA-DR CD38 double positives, and these are increased in sepsis HLH as well as all HLH pooled together as compared to sepsis. The T cells which are expressing PD-1 are also increased in HLH group than in the sepsis. These are the flow plots showing representative of from each category, where you see the double positive activated T cells are negligible in sepsis. It's 22.8% in sepsis HLH, whereas it's higher, even higher in primary HLH. Next, we looked at the activated T cells in the T cell subsets, CD4 T cells, as well as PD-1 expressing CD4 T cells. Similar trend was seen that CD4 activated T cells were higher in HLH groups. Similarly, PD-1 expressing CD4 T cells were also seen to be higher in sepsis HLH group. Similar trend was seen for CD8 T cells, though between sepsis HLH and sepsis, it's not significant. The trend is towards higher levels, higher percentages of activated CD8 T cells, whereas all HLH pooled together show a significant difference in the significant increase in the activated CD8 T cells in the HLH as compared to sepsis. Also, PD-1 expressing CD8 T cells are also showing similar trend with a significant increase in the HLH group than the sepsis group. So next we explored the cytokine profile, though we have very few numbers for the cytokine data for very small number of samples. So the top three shows the sepsis, children with sepsis. B stands for bacterial sepsis, V stands for viral sepsis. And the bottom ones are HLH. The U stands for unknown infection, and O stands for other secondary HLH. So as you can see, the pattern of the cytokines which are highlighted in the red are in the red box are kind of upregulated in HLH, where it's almost negligible in the sepsis group. So these cytokines, we have also compared the median levels individually between sepsis and all the HLH pooled together. We do see a significant increase in the IL-2 receptor levels in the HLH, along with IL-10 is also significantly elevated, IP-10 and MIG. These are the key which are cytokines which are significantly elevated in the HLH group than the sepsis group. So the elevation in IL-1 RA and IL-10 might indicate that the regulatory mechanism is also active in the HLH, along with the enhanced inflammatory mechanisms. MIG and IP-10, which are basically chemokines responsible for recruiting T cells for recruiting T cells to the site of inflammation, and they also suggest interferon gamma activity. And the cytokines, yeah. So to conclude, so far what we are able to conclude from a study that sepsis-associated HLH show reduced cell numbers and elevated activation, soluble activation markers as compared to the sepsis alone. And in T cell profile, we see reduced lower CD4, CD8 ratios, increased percentages of activated T cells, increased percentages of PD-1 expressing T cells, both total T cells as well as subsets in sepsis in HLH as compared to sepsis. And cytokine profile also show a distinct pattern of cytokines which are elevated in sepsis HLH, mostly under these categories: regulatory, T cell activity, and interferon gamma activity. This study is still ongoing, and in future we are still we have planned to do cytokines on the remaining set of samples, and we have samples collected for transcriptome analysis also. I would like to thank the people who had contributed and in the lab work as well as funding the project. And thank you, sir.
Thank you. We are still a little bit late, so if there is one question on the floor. Otherwise, and not in a... Thank you very much. Oh, sorry.
Hi.
Hi.
Have you looked in the frequency or activation of unconventional T cells, for example, mate cells, because
No.
they are more relevant for bacteria? It will be easy to analyze. You can just include 2 extra markers, and it might be very informative.
What will be the 2 extra markers? Can you?
CD161
Yeah.
and TCR-V alpha 7.2.
Okay. Do you see that these cells in enough proportions in circulation?
No, but it depends on how many cells you analyze. And
Okay.
there has been a group in our department that has looked in sepsis patients, adult sepsis patients, and they have found significant decrease in mate cells.
Okay.
But those mate cells that remain in circulation are highly activated.
Oh, okay.
So, yeah.
Yeah. Thank you so much for the suggestion.
Thank you. Now, yes, I think we have to go on because we are a little bit late. Thank you.
Thanks.
Sorry, Eli Diamond on mixed histiocytosis and the treatment.
Hello. Hi again, and thank you for the opportunity to present this work. I'm going to present a multi-center series of 26 patients with mixed histiocytosis. Thank you. Those are the same disclosures. So we received a very erudite and scholarly review of mixed histiocytosis from Arturo yesterday. So he's relieved me of that responsibility of saying anything substantial about the history. I'm just going to make a few points by way of background, which is that what has been learned from large series of this entity, first from the French group, is the ECD-LCH overlap entity, the fact that it is more of an ECD-like clinical phenotype in that series. I'm not sure that this was sort of highlighted as a goal, but sort of in retrospect, what I saw in that series is that relatively poor response to interferon as compared to the broader ECD population, the nearly invariable association with the BRAF mutation, and then worse survival with patients who were diagnosed dysynchronously. And then sort of another series about the ECD-RDD overlap that we did with the French group, highlighted this as an entity that happens more in males, with frequent MAP2K1 mutations. Also, again, this wasn't, I think, what we were looking for, but there were essentially poor responses to conventional treatments in this group, especially this phenomenon of emergence of Rosai-Dorfman during treatment for ECD. And then there's Arturo's systematic literature review proposing these 3 types of mixed histiocytosis: the multi-system, sort of concurrently diagnosed, the quote-unquote therapy-related, which is to say one emerging on treatment for the other, and then single-system biphenotypic lesions. So in looking at a larger cohort of these at our center and others, I was trying to see what can be learned from sort of a comprehensive characterization, sort of a uniform comprehensive characterization of patients like this. Is there molecular characterization to be done beyond BRAF V600E and MAP2K1? And then what are the treatment outcomes for these patients? Essentially, is there anything clinically at stake in having a mixed disorder as opposed to one or the other? So this is a collaborative study between my institution with contributions from several others. These are patients with histologically confirmed, one of these mixed entities. All of these cases were reviewed by the MSK group, which is to say Mark Rosenblum or Amit Dogan, and then one of the outsiding collaborators. And these are patients who either have sort of spatially, temporally separate diagnoses of 2 different subtypes, or what we'll call biphenotypic lesions, which is to say coexisting under the same slide. I'm going to present sites of disease, whether the entities were diagnosed concurrently or asynchronously, and then all the mutations observed, and then a focus on responses to conventional versus targeted therapies. This was mostly ECD-LCH patients, some ECD-Rosai-Dorfman, and then one RDD-LCH overlap and one patient with all three. About a third of the patients were diagnosed at the same time, and then the majority were diagnosed differently, and then these were mostly men. If you sort of look at which was diagnosed first, consistent with the French prior observation, the majority of the ECD-LCH overlap were diagnosed with LCH first. However, some had the non-LCH component diagnosed later in our group. And then, there's very few ECD-RDD patients to make an observation, but 3 of the 5 were diagnosed concurrently. And then same for the single LCH-RDD group. The patients who come to me are more likely to be, I think, just multi-system as a selection issue, but there's a predominance of neurologic and bone involvement. I'm going to go through the specific variants, but the mutations observed in the group were BRAF V600E in MAP2K1, MAP2K2, MAPK3, which is ERK1, RAS, a non-V600 BRAF, 1 fusion, and 1 RAF1, and then one person, no matter how hard we looked, we couldn't find anything. In terms of the biopsies themselves, so there was 82 biopsies in these 26 patients. 14 of those were biphenotypic, which is to say both histologies under the same in the same sample, and of those, 8 were mixed ECD-LCH, and the rest, there's 5 ECD-Rosai-Dorfman. Looking at here, I'm trying to think about, is there any particular organ that has the biphenotypic histologies, and I don't really think much comes out in the wash. This is really just a distribution of the different diagnoses by organ system. I guess there was a bunch of the ECD-LCH found in the skin, and some of these with neurologic biopsies. This is the portion of the talk where I drive out of my lane and talk about histology, but this, in my mind, is sort of a mixed ECD-LCH. There's the histiocytic infiltrate with sort of elements of CD1A positivity, and I understand that this is, I'm gonna mess this up. I think this is more of the LCH type, and this is more of the non-LCH. And then this is a biphenotypic Rosai-Dorfman with LCH with emperipolesis, and this here is more of an LCH type infiltrate, all CD68 positive and sort of a demarcated CD1A element. I get Jean-Francois' smile, so I didn't mess that up too badly. And then this is the actual variance observed in this population. So in the ECD-LCH group, there was 2 MAP2K1 mutations, the one that I talked about yesterday. One of these had an ERK1 mutation, a BRAF deletion, and then the BICD2 BRAF fusion that we've sort of described in other contexts. The ECD-Rosai-Dorfman, so MAP2K1, as we've seen in the past, but there was one of these patients with KRAS and one with a RAF1 mutation that we've also described in a different context. And then the RDD-LCH patient had a MEK2 mutation, MEP2K2, and then the patient with all 3 was BRAF. In terms of treatment, we summarized it in terms of instances of conventional versus targeted therapy. So there were 66 instances of systemic treatment in this population. Of 37 instances of conventional therapy, there was only about a third had any complete or partial response. And then if you include the stable disease in the denominator, 13 of those 19 had subsequent progression. So very few in this population lasting responses to what we call conventional therapies. And then the BRAF and MEK inhibitors, very large proportion with complete or partial responses, some with stable disease, and 5 with subsequent progression. And as with my other talk, progression is radiologic. And so, in the targeted therapy era, patients are getting more scans. So I think there's probably more readily detected progression than in some of the sort of serial conventional therapies who may have been not evaluable. Just because progression on targeted therapy gets everyone's ears up, just to provide the details about those patients, these were either progression on very, very low dose treatment that was recaptured with a dose escalation, patients who had stopped and then were followed, I counted those as subsequent progression, but that's not a surprise. So patients who progressed after discontinuation of targeted therapy, and some of these were patients with neurologic progression on low-dose treatment. This is a swimmer's plot of this population. So what we have here is the disease on the left, the mutation on the right, and the 0 time point I chose to be initiation of targeted therapy, because I think that's kind of where the message is here. So there's, some patients who are observed only. That will always be a small subset. These are the targeted therapy patients who, essentially have their lasting responses, and then the patients treated with conventional agents prior to targeted therapy, as from the table, generally are having progression events and are ending up on targeted agents. Oops. I'm going to do it again. So this is just a couple case examples. So this is a patient with, LCH on the cheek and a xanthelasma. There's a non-LCH on the left. This was a young man treated with very many regimens for long-standing LCH. At his initial evaluation, I sort of noted the xanthelasma, and then his PET CT had tibial lesions. He has a BRAF in-frame deletion. He's enjoyed a very prolonged response to cobimetinib, and he's sort of an evolution of an LCH phenotype to an ECD phenotype. And then one sort of pattern that I would say I've noticed in these cases is patients with LCH. These are very typical LCH manifestations, mastoid, lymph node, vertebral body, but it's just sort of blowing through cytarabine. And then upon sort of a full reevaluation, non-LCH noted in the skin, at the time of progression of LCH on chemotherapy, and this patient has had a lasting response to MEK inhibition. So overall, I think what I've learned from this is that this is a more mutationally diverse sort of entity than I had appreciated, and there's sort of more LCH-like phenotypes with non-LCH elements and the opposite. One clinical message for me from treating these patients is that I pay very meticulous attention to looking for any bit of ECD or non-LCH, even just in the skin, in the LCH staging evaluation, because I think that those people will invariably not do well with chemotherapy, and I will probably start targeted therapy first. And as I said, this is an entity that's responsive to targeted therapy. And that's all. Thanks.
Thank you. I personally have several questions, but we are still a little bit late. Is there? What? Yes, please.
Thank you, Eli, for a very nice talk. I was just wondering, as far as I could see, but maybe just went a bit too fast, a lot of these patients were still on targeted therapy, so that means you haven't tried stopping therapy yet?
So I would put as a separate conversation my experience with stopping. I have stopped some, and there's a select number of sort of non-BRAF patients that have had lasting remissions after stopping. But in general, I find it hard to talk patients into stopping because they don't want to feel the way they did before. But that question is not addressed in this data.
Yeah, because my follow-up question was a bit sort of how you feel about having them on long-term targeted therapy, considering the side effects that have been seen in adults on inhibitors.
I think there are many dosing strategies that get around most of the side effects. Yeah.
A small question while the next speaker is is preparing. Okay. Yes.
In the ECD, RDD, mixed histiocytosis, do you have any patient developing arthritis?
Not as a consequence of treatment, but as a disease manifestation.
Yes, as a disease manifestation.
Not readily coming to mind. Yeah.
Thank you.
Okay, I will ask you my own question later.
Okay, later? Okay. Oops, sorry. That was telling me to be quiet. Okay. Thank you.
Thank you. So the next speaker is for a subject we haven't addressed since well, I think I haven't heard about it, except Dr. Francis, maybe, was it supported by the Histiocyte Society Association?
Right.
Yes, so it's a success. Thank you.
Good afternoon, everyone. I'm Jasmine Francis. I'm an ophthalmic oncologist at Memorial Sloan Kettering. It's an honor to speak to you today. I would like to acknowledge my co-authors, including Dr. Eli Diamond. I have no financial interests or commercial relationships. I will be discussing the off-label use of drugs. So why am I here speaking to you today about vision and the eyes? Why is this of importance to our patients? Well, if you use a trade-off model and you ask patients who are legally blind how much of their remaining life they would give up to have normal vision, they would give up half of their remaining life. So it's clearly important to our patients. Histiocytosis can affect the eyes through disease. It can also affect eyes through treatment. And I'll start by talking about the former. This was a study that characterized the frequency and the nature of ocular findings. We detected abnormalities via ophthalmoscopy, but also through multimodal imaging. These patients received an ophthalmic exam as part of their baseline evaluation in anticipation of them starting targeted therapy. And we looked for associations between clinical disease features of histiocytosis and ocular findings. It was a retrospective review over 8 years, and we used descriptive statistics. We had 182 eyes and 91 patients, evenly split between male and female. And here are the subtypes of histiocytosis. You will note that it is heavily weighted towards the non-LCH subtypes. Of 91 patients, 43% had ocular findings that were distributed through these various segments of the eye, and I will individually go through those and make some comments. So we'll start with the eyelids. 9% of patients had eyelid involvement, and of those 9%, you can see here the distribution between the different subtypes, and LCH here does feature. As we know, this is predominantly in the form of a xanthelasma. And just to emphasize here that xanthelasmas can be a very rich source of genetic information. It is easy to biopsy in the office the same day. It heals well. This is a week later. This is about 3 months later, and you can see the good healing. The orbit involves everything but the eyeball. About 12% of patients have involvement. And there are distinctive orbital findings in these patients, and the problem comes because of the small aperture of the optic foramen, which can result in optic nerve compression. Here is a little quiz. I'm sure you can see here that this scleral show, the appearance of the sclera tells you that this is the eye that's involved. Amongst the subtypes of histiocytosis, you can see them distributed here. While orbital disease does feature an LCH, in our group it did not. And here is an example of a patient who has disease in their right orbit, who had a very nice response following intra-arterial melphalan to the orbit. So this was an impressive and a sustained response. The anterior segment involves the anterior chamber, the ocular surface, and the lens. Here you will note that Rosai-Dorfman has a high propensity of involvement, and you'll note a lack of xanthogranuloma and also LCH. Here's an example of Rosai-Dorfman in the cornea, an example of uveitis and scarring of the iris to the lens, which resolves with topical steroid treatment. And here's a striking example of a painful nodular scleritis that was refractory to MEK inhibition. Other sites responded to MEK inhibition, but this patient had a very nice response to, you guessed it, intra-arterial melphalan. Posterior segment involves the retina and the choroid. And just as a reminder, these layers are like the wallpaper in the eye. We use our imaging and our instruments to do a fundoscopic exam. We also use optical coherence tomography, which generates a cross-sectional image of both the retina and the choroid. And I'm showing you here the symptoms of what patients can experience when they have either retinal or choroidal disease. Again, to emphasize that histiocytosis occurs in the choroidal layer, which is beneath the retina. So about a quarter of our patients had involvement of the posterior segment, and the vast majority of these were patients with ECD. Here's an example of a fundus image of ECD in the choroid. Here is a normal OCT image. This is an abnormal OCT image, so histiocytosis infiltrating the choroid, pushing the retina up. Here's another example, a little more subtle, although I've pointed it out right here. And you can see on the OCT we have normal choroid, infiltrated choroid, normal choroid. When we examine these patients, we also look for features that are predictive of toxicity from targeted therapy. And to point out here that when we see crowding of the optic nerve by blood vessels, this is a predisposing feature to a vein occlusion. This is to show you the heterogeneity of the fundus findings in histiocytosis in the choroid. And then this is an additional observation which is not accounted for in this current study, but we looked at the OCT findings of the choroid. We looked at a normal gender and age matched controlled group to our histiocytosis group, and we found that patients with histiocytosis had a statistically significantly thickened choroid compared to normal. And this is otherwise in an eye that when we look with fundoscopy is completely normal. And just also to emphasize again that OCT is a non-contact imaging device. It's quick, it's accessible, and it's routine. Neuroophthalmic manifestations occur in the optic nerve and in the cranial nerves. Here is an example of an edematous nerve, so an acute presentation, and then when there's chronic damage to the nerve, it looks pallorous and atrophied. Now for the associations. So here you can see all of the ophthalmic manifestations divided by the subtype, and you will note that compared to LCH, the non-LCH subtypes were statistically more likely to have ocular findings, and this was particularly true of the posterior segment. Eye findings were not different by BRAF V6100 subtypes or aberrations. However, patients with neurological sites of histiocytic disease were statistically more likely to exhibit ocular findings. Thankfully, in the best case scenario, once disease had regressed, the vast majority of our patients still had useful vision that we classify as able to legally drive. But this emphasizes the point of detecting disease in the eye early on to allow for these good results. I will just very briefly touch on how treatment can impact eyes in patients with histiocytosis. So uveitis is an inflammation of the anterior chamber. 5% of patients on a BRAF inhibitor will develop this. There are 4 main symptoms: pain, redness, photophobia, and blurry vision. The way to treat this is with topical steroids and a cycloplegic. In addition to that, the retinitis that was mentioned earlier, cystoid macular edema, can occur in 1% of patients on a BRAF inhibitor. This results in painless, blurry vision, and this can be treated with steroids. Serous retinal detachments are probably the most common side effect that we see. Upwards of 15 to even 45% of patients on an ERK inhibitor can develop this, although at the doses that are used for histiocytosis, those numbers are most likely lower. This gives you an example of what patients will experience when they have these foci of fluid under their retina. Thankfully, this is reversible, this can be observed, and patients can continue on treatment while this spontaneously regresses. And then the most feared of all complications is the retinal or artery vein occlusion. This occurs in a small minority of patients, about 0.3% of patients on a MEK inhibitor. Many protocols necessitate that the drug is stopped. we have had some success in treating patients with anti-VEGF injections into the eye. So in conclusion, 43% of patients with histiocytosis have ocular findings. This is heavily featured in non-LCH versus LCH. There is an association with neurological sites of disease, but not with mutational status as far as we know thus far. And our future steps are plans for a longitudinal assessment to answer questions such as, are ocular findings a predisposition to treatment toxicity? And could ocular imaging, including this non-invasive OCT, be an indicator of treatment response? So we know that histiocytosis can hide in the eyes, and I think you will also appreciate that the eye can hide in the histiocytosis icon. Thank you.
Thank you for this excellent didactic talk. Well, ophthalmology, I think everybody understood it, that it's not only before targeted therapy, it's, it's for most of the patients. Thank you. Do you have questions? Yes? Carl?
Really interesting talk. You know, I guess maybe one thing I'd ask your advice and maybe help on is, I find that when we have to engage our ophthalmology colleagues, especially pediatric ophthalmology colleagues, they're sort of at a loss for histiocytic diseases, and I think there's more experience with managing like MAP kinase inhibitors, but if there was some sort of document or how I treat the eyeball and histio, that would be amazing that we could share with our colleagues.
That's a great idea. Well, thank you for the idea, and I don't know how much of it exists. Much of the literature is based on case reports and small case series. So to put all that information together would make sense.
Yeah, I think that just anything to help with practical care of these patients with, especially at centers where they don't have the benefit of Eli's volume that he directs to share with you. So thank you.
Dr. Lorenz is here? Okay. You have the microphone. Okay.
Next. Hi, I'm very excited to attend my first Histiocyte Society meeting and present this data on behalf of my collaborators. So this is a follow-up work to a paper we published at the beginning of this year. Oh no. Okay. So what we know about HLH in the context of malignancies is that it looks very similar to familial HLH. So we take everything that is learned from familial HLH and we extrapolate the diagnosis and treatment, but still prognosis is very poor, and around 20% of the patients survive long term. Earlier this year, we developed a simplified diagnostic and prognostic index termed the Optimized HLH Inflammatory Index, which is comprised of the combined elevation of soluble CD25 above 3,900 units per ml and ferritin above 1,000 nanograms per ml. The challenge was that most of the HLH diagnostic features can be created by the malignancy itself. Big spleens, decreased blood counts due to the tumor invading the bone marrow, fever, so it's very hard to distinguish. So we collected above 200 cases worldwide, 3 centers in Israel, 2 in the US, 1 in Japan, of patients with malignancies that had all HLH diagnostic features and other related features examined either because of HLH suspicion or as a routine at the malignancy diagnosis. And we did CART analysis and ROC analysis to try to understand in a very unbiased approach which of these parameters best predict the development of the entire syndrome, the 5 out of the 8 diagnostic criteria. And we identified that soluble CD25 and ferritin best predict the development of the entire syndrome. But even more importantly, when you look at those Kaplan-Meier curves, patients that were identified by the OHI index, those in red, we saw that the OHI index is able to identify a larger portion of the patients that are at high risk and are currently not identified by either the HLH 2004 or the H-score. But even more interesting, you can see that patients that have partial OHI, which means just elevated ferritin in orange or elevated soluble CD25 in blue, also have decreased survival, while patients that do not have any elevated inflammatory markers do remarkably well, around 90% overall survival, which we found fascinating. So we think that there's something about inflammation in these patients with hematologic malignancies that is really important and worth further investigating. But we also asked ourselves, are these patients dying from inflammation, or maybe it's just that incidentally they have a worse malignancy, that it is more aggressive or more advanced? So we decided that we need to go back to our collaborators and examine this question in very thorough and detailed ways. So we designed a study to determine if those OHI positive patients are dying directly from their progressive malignancy or from HLH associated causes. So again, it's a multi-center retrospective study of the same cohort, but now focusing on lymphoma patients. So our primary objective was to determine the added value of the OHI index to the malignancy-relevant international prognostic index in predicting mortality. So we took, for each patient, the international prognostic index evaluated at diagnosis, and we compared the predicted mortality to the observed mortality, and to determine the mortality, the causes of mortality of OHI positive and OHI negative lymphoma patients. And as a secondary objective, we also aim to describe the difference in malignancy features between OHI positive and OHI negative patients. Okay, so we used, in order to compare the malignancy characteristics between OHI positive and negative patients, we used the Mann-Whitney test, and we calculated the individual disease-relevant prognostic index, and we calculated the odds ratio of the added risk of the patient's mortality risk using the chi-square test, and we also described the immediate and underlying causes of mortality using proportions. Okay, so international prognostic index. So most of our patients were non-Hodgkin's lymphoma, so we used the international prognostic index, the IPI, but for follicular lymphoma we used the FLIPI, and for patients with Hodgkin's lymphoma we used the international prognostic score. And because most of the patients were non-Hodgkin's lymphoma, we used the individual prognostic markers like Ann Arbor staging and ECOG performance status and extranodal sites to compare the extent of the disease at diagnosis, to try to answer the question, are these patients, do they have a more extensive disease at OHI evaluation? Sorry? Okay, so we included 100 lymphoma patients. 63 of the patients were OHI negative and 37 were OHI positive. 65% had non-Hodgkin's B-cell lymphoma. 80% had T-cell lymphoma, and a similar proportion had Hodgkin's lymphoma. And more than half of the patients had soluble CD25 and ferritin evaluated at the time of diagnosis. So MD Anderson at the US and Toyama Center at Japan are assessing those markers routinely at malignancy diagnosis. And when we looked at the malignancy features, you can see that in most of these features, the extranodal sites, the ECOG performance, and the disease-relevant IPI, OHI positive and OHI negative patients were very similar to each other. However, in the Ann Arbor stage, OHI positive patients had a slightly more advanced disease. You can see more patients having a stage 4 disease in the OHI positive group. But when we looked at the predicted versus the observed survival, the predicted survival was very similar between OHI positive and negative patients, while the observed survival was remarkably different. And when we calculated the added risk for these patients, OHI positive patients had a 4 times higher risk of dying, while OHI negative patients were protected. They had a better prognosis than what the IPI had predicted for them. And when we went ahead and examined the reasons for mortality, so OHI negative patients, more than 50% of the patients were classified as having the immediate cause of mortality being progressive malignancy. Some had, in yellow you can see sepsis or shock. A lot of these patients have inflammations, hemorrhagic stroke, DIC. But when we looked at the OHI positive patients, more than 60% of these patients died from multi-organ failure, which is the closest term of saying died from HLH. But also when we looked at the other reasons, you can see in yellow sepsis or shock, and then you have the organ failure. In blue you see dark blue respiratory failure, and also liver failure in the brighter blue, and all the infections in green, which also make 9% of the patients bacterial, fungal, and viral, and also intestinal bleeding. And so only 3% of the patients who are OHI positive were defined by their physician as dying directly from their progressive malignancy, while all other causes are directly related to the HLH pathophysiology as we know it. When we looked at the underlying causes of death, so again, OHI negative patients, more than 80% died from their progressive malignancy, and in OHI positive patients, so a much larger proportion was related to the lymphoma, more than 50%, but still a big proportion of infections in green, and neurologic involvement in yellow that was defined as HLH involvement in 2 patients. And you can see massive splenomegaly. We had a patient that had massive splenomegaly and then splenectomy, was immunocompromised, and in the end died from sepsis. And when we look at those causes of mortality over time, you can see that in OHI positive patients, so the mortality occurred much earlier. In green, you can see those infections that occurred early on the disease course, but also the intestinal bleeding. And most of the patients that died early died from multi-organ dysfunction. So the median time to death was 181 days in the OHI negative patients, median time to death from the patients that died. And in the OHI positive patients, 118 days, when mortality that is directly caused by multi-organ failure was shorter, 75 days. And when we looked at the lymphoma response to treatment at last follow-up, you can see that it did not differ between OHI positive and negative patients. You can see on the left the patients that lived. It was quite similar between stable or progressive, partial response and complete response, and in the deceased, again, non-significant difference between those groups. So, to conclude, OHI positive patients had a slightly more advanced lymphoma, but were generally similar to OHI negative patients according to their lymphoma-related prognostic index. And OHI-positive patients had a significant added mortality risk, while OHI-negative patients were protected in our cohort. And OHI-positive patients died mostly from multi-organ dysfunction, while OHI or infections or other organ failure or bleeding, while OHI-negative patients died mostly from causes related directly from their lymphoma. And there was no difference between those groups in the lymphoma treatment response at last assessments. So we conclude that the OHI index identifies a harmful inflammatory state that deserves further prospective study. I want to thank all my great collaborators in the US, in Israel, in Japan, Joanne sitting here in the audience, and Michael, my amazing mentor. Thank you.
Thank you. Yes, question? Is there any? No. No.
Okay, now, thank you for a very interesting talk. I was just wondering, do you know if there was any difference in the HLH-directed therapy that was given between these different groups of patients?
This is a great question. So this is part of the data that I'm waiting to get back from my collaborators. So in the first day I was describing, we're doing a big project about treatments and analyzing treatments. So we're gathering very detailed data. So I have some of the data. Overall, most of them were treated for their lymphoma. So actually, Sharat from Cincinnati is here. When we discussed this data, he gave a very interesting hypothesis that maybe these patients, because they are recognized as having HLH, then that to itself might be hurting them. So I think that's an interesting hypothesis worth investigating, and we're asking our collaborators, did the treatment alter due to HLH concerns? So we'll be able to answer this question. And
last question.
Hi, along that vein, will you have access to transferrin saturation and then CD25 of either the TILs or the tumor to know if you actually have, even though your burden of disease seems similar, but do you somehow have a different phenotype since CD25 is so common in this population to drive your SIBIL2?
This is a very good question. Unfortunately, no, but I think it's worth further investigating according to what we discussed earlier in the meeting. So no.
Thank you.
Else?
I think we have to end the session. And thank you.
Thank you.
I will give place